Hello, my name is Patil Mksyartinian. Welcome to my presentation towards Patient-Centricity, a casebook on using patient experience data known as PED in health technology assessments. During this presentation, I will be going over what is patient experience data, why is PED important, FT3's casebook overview, Colorectal Cancer Canada's casebook example, and PED future directions and implications. So what is patient experience data? As defined in the 21st Century Cures Act, patient experience data includes data that's collected by any persons. This includes patients, family members, caregivers of patients, patient advocacy groups, disease research foundations, researchers, and drug manufacturers. This is intended to provide information about patients' experiences with a disease or condition, including the physical and psychosocial impacts of such disease or condition or related therapy or clinical investigation on patients' lives, and patient preferences with respect to treatment of such disease or condition, and also the impact of the treatment on their quality of life. Patient experience data may include multiple distinct evidence types, such as preferences, experiences, and perceptions. For preferences, as you can see in the figure here, patient preference studies using discrete choice experiments and best and worst scaling are most commonly used. Regarding experiences, patient-reported experience measures known as PREMs are used. And then regarding perceptions, patient-reported outcome measures known as PROMs are used. And these can be collected using quantitative and or qualitative methods. Regarding preferences, more so quantitative, as you're using discrete choice experiments and best and worst scaling. So you could look at the trade-offs between treatment characteristics, looking at experiences. This can be done qualitatively using interviews and focus groups. For perceptions, you can do surveys on satisfaction or treatment burden. Sometimes with patient preferences, they're confused with PROMs and PREMs. Although they're all patient-reported measures, they do differ. With PREMs, this can be the report of any patient's personal experience with their health and the healthcare services they've received. In comparison, patient preferences can be used to value a broader range of aspects of care. So this is beyond clinical outcomes such as survival and quality of life, and can include aspects of care delivery and non-health outcomes such as mode of administration. So why does patient experience data matter in HTA decisions? Well, it's really important for understanding patient priorities in decision making, especially in areas of high uncertainty, such as for rare diseases, cell and gene therapies, and targeted therapies. Also, it provides insights into what patients value and the trade-offs they're willing to make beyond traditional clinical outcomes, such as the side effects they're willing to endure that can be captured through patient preference studies. Also, it adds patient knowledge into HTA decision-making that ensures relevancy and consequences of new technologies. For example, looking at their ability and willingness to continue taking a medication, the side effects, the impact and experiences, their perspectives on the timing of the administration, unmet needs. So there's different areas that PED can capture beyond those clinical outcomes. Also, it improves HTA dialogue and decision-making by incorporating real-world patient perspectives and experiences into the deliberative process. And it supports patient participation into HTA, enabling meaningful contributions before, during, and after deliberation. So this can be during the consultation input, through community roles, and also through patients with lived experience presentations that the CDA has recently started to offer. So now I'll be providing an overview of the FT3 casebook. FT3, known as From Testing to Targeted Treatments, is a nonprofit global multi-stakeholder collaborative initiative co-led by patients. With the casebook, it's really looking to provide examples of diverse PED collection methods used in HTA submissions or advocacy to offer insights on what method is helpful when to capture what and how this may support decision making. So it really demonstrates how PED can capture patient perspectives and inform HTA decision making. So the project goal is to evaluate the use of PED by HTAs to facilitate more patient-centric value assessments. So I'll be providing an example that we shared in the casebook from Colorectal Cancer Canada. So now we'll be going over a case example from the FT3 casebook on PED methodologies for HTA decision making. So just to provide a quick overview about the HTA process in Canada, HTA decisions are guided by Canada's drug agency, the CDA, for all of Canada except Quebec. In Quebec, it's completed by INES. So there are opportunities for patient experience data within the HTA process in Canada. So patient input opportunities and clinician input opportunities do exist. But for patient input, this isn't systematically collected or quantitatively included. So it's more so anecdotal using qualitative methods. Also, a weight is not applied to patient input, so it's unclear how this information is considered and influences the HTA decision-making process. So there is a recognized need for quantitative preference evidence to consistently reflect what matters most to patients. So looking at our PVP study, our patient value study aims to explore approaches to incorporate patient preferences into cancer treatment decision-making processes. So this project really aims to assign weights to patient values, enabling a more objective representation of what patients consider most important. And it can also ensure that patient voices are systematically included in cancer drug reimbursement decisions. So now we'll be looking at our patient preference study entitled Patient Preferences for Metastatic Colorectal Cancer, a multi-method approach using discrete choice experiments and best and worst scaling. So the purpose of the study was to really integrate patient perspectives into HTA and drug reimbursement decision-making in Canada, to define, measure, and assign weight to patient values in metastatic colorectal cancer treatment, and to generate quantitative patient preference evidence that can be used in HTA and reimbursement decision-making. So the study population included Canadian adults aged 18 and older who were diagnosed with metastatic colorectal cancer and who were currently in treatment or who had past treatment experience. So we had a multi-method approach using patient preference surveys. So we had 2 discrete choice experiments and 1 best and worst scaling. With the discrete choice experiments, with the first one, it looked at capturing areas such as overall survival versus health-related quality of life. For the second discrete choice experiment, it looked at route of administration and frequency of side effects and progression-free survival. And then for the best and worst scaling, it was more so looking at which side effects were considered more tolerable. So you can see an example of the discrete choice experiment and the best and worst scaling survey here. And then what we found was interesting from the 127 participants with MCRC who completed the full survey, patients valued overall survival and quality of life almost equally and preferred longer progression-free survival and fewer side effects, and showed a lower preference for oral pills compared with IV infusions. And then the least tolerable side effects were need help with eating, dressing, and washing yourself, or using the toilet, vomiting, and pain. So those were some of the key results that we found from this patient preference study. So looking at the study impacts and barriers, regarding the study impacts, we strengthen the patient voice in the HTA discussions by providing quantitative patient-derived evidence on what matters most in metastatic colorectal cancer treatment. We improve credibility of patient input through the use of validated research methods using the discrete choice experiments and the best and worst scaling. For the first discrete choice experiment, so the DCE1, this highlighted that overall survival and health-related quality of life are equally important priorities for patients. And then for the second discrete choice experiment, so the DCE2, this highlighted that patients preferred better outcomes, so longer progression-free survival and no side effects over worse outcomes. And this does really provide a robust foundation for integrating patient perspectives within Canada's HTA framework. Although there are a few barriers to consider, so currently there's no standardized framework yet to systematically integrate quantitative patient preferences within the HTA process, and it's unclear how this data would be weighed or applied in reimbursement decisions. Small and non-representative samples would face recruitment challenges, and also there are limited resources and expertise available to patient groups to conduct these complex preference studies. And there's also a need for international alignment and training to ensure consistent interpretation of patient preference evidence. Now I'll be discussing the implications and future directions of patient experience data in HTA. So validated quantitative methods such as patient preference studies are valuable for HTA to trust and compare patient input across studies. For example, using a multi-method approach using discrete choice experiments and best and worst scaling can provide a comprehensive understanding of patient treatment preferences, risk tolerance, and patient-centered value drivers such as quality of life improvement and adherence considerations. Triangulating different methods strengthens the evidence base for integrating patient perspectives into HTA decision making. Also, incorporating preference weights into cost effectiveness analyses can ensure that evaluations better reflect real world patient trade offs and quality of life priorities, and they also ensure that the deliberations are more transparent as well. There's also a clear need for standardized methods to operationalize the integration of patient preferences and other patient experience data methods beyond the ones that are already used by HTA agencies that collect patient input through surveys and focus groups as well as interviews. So this can include more so the quantitative methods that were discussed that can collect areas such as PREMs and PROMs as well. And there's also the consideration of novel value drivers such as option value, scientific spillovers, and adherence factors alongside PED that can provide a more holistic assessment of treatment value and societal impact as well. Thank you for taking the time to listen to my presentation. I would also like to thank the CDA Symposium for allowing me to prepare this video presentation. If you have any questions about the presentation or the content that I discussed, please feel free to send me an email at patilm@colorectalcancercanada.com. Thank you again for listening.